Please stand order. Could we bow for the invocation? Counselor Austin, would you please lead us?
Gladly. Lord, it is always a privilege to stand in this room with these people with the responsibility to do the good for the Cherokee Nation and the people of it. We ask that you guide us, that you lead us, and that we seek your wisdom in all decisions. Protect our people from various health challenges, and please be with all those who serve our country through the armed services, through the putting on the uniform of a firefighter, of a policeman, and help them to be safe and to be strong. In your name, we pray together, amen.
Mary Baker Shaw.
Honey.
Mike Dobbins.
Here.
Keith Austin.
Here.
Harley Buzzard.
Here.
Joe Bird.
Honey.
Lillian Coates.
Here.
Sean Crinden.
Here.
Joe Deere. Hayden Duncan.
Honey.
Rex Jordan.
Here.
Darrell Legg.
Here.
Wes Snowfire. Dora Petkowski.
Here.
Mike Shambaugh. Leo Smith.
Here.
Denise Taylor.
Here.
Victoria Vesquez.
Honey.
We have a quorum.
Thank you. Thank you so much. Okay, now for approval of the minutes.
Make a motion they be approved.
Motion made.
Second.
All those in favor say aye.
Aye.
Okay, our first report, Claremore Service Unit. Is George with us today? Mr. Velour?
You're not
Value.
Valier. I'm going to learn to say that. I promise I'm going to. Poor George. Okay, well, he's not with us, so let's go to Dr. Jones. Hi, Dr. Jones. How are you today? Dr. Jones, can you hear us? Good morning.
Me okay?
Or I guess good afternoon. Y'all all staying safe over there? You staying safe up there at our new clinic? Dr. Jones?
Marty, can you hear me okay?
Yeah, can you hear me?
Yes, I can now. Yes.
Okay, good. I was just inquiring, is everybody staying safe up there at our new outpatient clinic?
Absolutely. We're doing all we can to mitigate this group as safe as we can.
Well, you know, I think so many people are relaxing, and of course, we're seeing the numbers spiking, but we're still in the middle of a pandemic, and I hope everybody remembers that. And I applaud your all's efforts to stay safe by not showing up into council. So thank you for that. Would you like to go ahead and give us your report?
Sure. I'm glad to go ahead and start. So I think you all have your reports in your packets. I'd like to read this first page just on so those that don't have a copy of this can hear this. But our patients have a choice when it comes to health care, and the delivery of their children, having served so many women under challenging circumstances, is a true testament to the dedication of our staff at Cherokee Nation WW Hastings Hospital. In the midst of this pandemic, August turned out to be a record-setting month for the doctors, nurses, and staff at WW Hastings Hospital. The OB department delivered 104 babies, making this a record for live deliveries in the history of that hospital. So pretty large achievement, and our staff did it without any additional staff added, and they were able to work through it, and they did a fantastic job. So I just want to make sure we give them recognition for all the hard work and that they did in the month of August. We'll move on into the report, and as you can see on page 2, there's some informatics there, and we highlighted the 104 babies being born. On page 3, you can see the provider recruitment. We still remain at a very low vacancy rate. We have had an exceptional recruiting time here in the last few months. A lot of people are looking at our health system as a leader, so we've got some very, very good candidates that we're looking through the pipeline now and interviewing, and some great residents that are coming through our system. So it's been a good year for us on recruiting. Go on over to I guess on the same page, contract health, we're at 97.3% approval rate. And then on the visits and revenue, of course, our visits are a little down, of course, because of the changes that we've had to make, and we went through several months there with some challenges on how we're going to get patients into the clinic and converting over to telemedicine, and so we had some time when the dental clinics were closed, and we're ramping those services up slowly, so those patient visits will continue to improve and get better. And then if we look over onto the last page on prescriptions filled by site, you can see that we're still maintaining a large amount of prescriptions at every site, refills and new prescriptions. So there's a few things that I want to highlight and talk about that have come up in the last, and just kind of give some updates on some things that you may or may not know. So first of all, we'll start off with a little bit of a COVID update. We're still testing at our drive-thrus at every location. Currently, as of yesterday, we've tested 32,450 tests. We've had 2,647 positives in Cherokee Nation. Our case monitoring team continues to follow all the positive cases and help them interact and let them know when it's time to seek treatment, or if they're doing okay. We contact them each and every day and give them the ability to contact us directly. Currently, our case monitoring team is following 381 patients. We continue to do contact tracing and consultations with other entities to help them deal with the virus. We're also working on strategies to mitigate a surge if that should happen with flu season. Of course, that's the talk right now, as we're starting to see our numbers come up, but we're also entering into flu season. So with that, we have to worry about hospital capacity, and so we've been working tirelessly on what we're going to do to mitigate that should that happen to us and we get into a situation where we're not able to transfer high acuity patients out, and if we're able to, so we can house them and take care of them here. So we've been working on that plan extensively for quite some time. Dr. Mara and our medical team have worked with Gilead Institution, or Gilead, to get a clinical trial brought to Cherokee Nation. And we currently got enrolled and started taking applicants or taking patients for screening for that trial as of last week. And what that trial is all about is remdesivir. You've heard of that on the news lately. It's a drug that is administered that reduces the amount of time that a person takes to recover. It's always administered in a hospital, and usually a person has to stay in the hospital for a minimum of 5 days. So with this trial, it's an outpatient trial. The patients are monitored very, very closely, and they come in to an outpatient setting, get an infusion, and then go back home. And if this is successful and there's complications, then this would allow remdesivir to be used as an outpatient modality and reduce the amount of time a person's in the hospital and open that bed up for someone who's much sicker. Typically, people on remdesivir have not been at high acuity, so it's more of a monitoring status. And if we can open up those beds, that would improve across the nation. So we're a part of that study, and we started enrolling or screening patients last week. It's a voluntary study, and patients have the option. We let them know about it when they test positive, and if they want to participate, they have the ability, if they meet certain criteria, to participate in that study. Flu season. So we've started our flu clinics. We've started our vaccination efforts. So far, we've vaccinated about 6,500 people just through our drive-thrus and our events. We have 5 teams going out into the communities and doing vaccination efforts, and of course we have our drive-thrus open at each location. We've also made some accommodations to have our drive-thrus open at different times after hours. It's going to be not every day. We don't have the staff to staff that, but we have made accommodations for a couple of after-hour visits at each clinic so that those that are working, if they want to have access to that, they have the ability to do that. We also have just started our stroke readiness survey today, and that's something that our staff's been working on for several months to get ready for. The certification survey crew is here today to survey us and give us certification if we pass all aspects of it. And what this is just is more or less a test to make sure that we have everything in place, and we're giving our patients the absolute best care for acute stroke and get the patient ready to be transported for long-term care if that's needed. And with all that, I just want to recognize all the employees, the men and women who are working out with us each day and in health. We've had a lot on our plate. We've had a lot of our employees or a lot of our staff has been out either on leave or with admin leave, or they fit into one of those categories where we don't need to have them in the clinic. So we've had a lot of people that had to pick up extra duties and keep our health system running and keep it efficient, and want to make sure we recognize those folks each and every day. We send a lot of emails and send a lot of thank yous out, but in this environment, it's hard to do the traditional things that you would do to recognize staff, which would be, a cookout of some sort or ward assemblies and things of that nature. We don't have the ability to do that. So we have been working on a new governance structure for the last year, and part of that was a committee that we formed last month, and it is for patient satisfaction and employee appreciation. This committee is made up of employees across our system from every clinic, and they're going to help us and guide us in how we can do a better job and how they would like to feel appreciated, how we can engage patients to help us appreciate our employees. When patients have a compliment that comes out, we need to be able to engage the employee for receiving that compliment. So we're looking at different ways that we can do that and different ways we can reward our employees in this type of environment. It's just not the traditional environment that we would normally have in the past. So with that, I'll conclude my report and open it up for questions.
Counselor Crittenden.
Dr. Jones, do we have portable bathrooms at Hastings and the different clinics for the family members who are maybe waiting on their loved one in the hospital or clinic?
Outside,
Yep.
Is that what you're asking?
Mm-hmm.
Yeah, I don't believe we do. I don't think we do have that, so I can check and find out, but to my knowledge, we do not.
Hey, I'd sure like to see that done. I've had a couple calls, and of course, I've got another question down here, but there's some situations where I'm not leaving my loved one. If they're not going to let me in the door, I'm at least going to be in the parking lot. And so I would like to see, if possible, to get some of those portable bathrooms at Telequal and at the surrounding clinics. And doctor, what are some of the conversations? I know the obvious answer is, hey, there's a pandemic going on, but with the babies being born, and I work with a lady, good lady, that was her only daughter having a baby, and we all know what milestone that is. And it broke my heart. Of course, I understand we're in this pandemic, but are we having any conversations about, getting a space suit for the mother, and you'd have to be picky on who. I also work with a lady, her husband just had open heart surgery, and of course it's not at our facility, but I know we've got some serious diagnosis going on at ours. But man, I've always thought if I had a heart attack or something, I always just knew that at least my wife would be in the next room, maybe sign a paper. I know we'd have to be careful with it, but Cherokee families, as everybody here knows, we're close. I mean, close. And, you know, with the COVID even, having friends, we've all known friends, family. It hit my house pretty good, thank God. It was minimal, but one of my best friends, it was like he was going to Mars, making decisions. Hey, do I go on this ventilator sign here? You know, so I wonder about the conversation about when we can transition into something where we're working with those families in certain situations. Thank you.
So we do have a team that looks at this all the time, an infectious disease team. It's made up of several of our medical staff, and we not only have to take in consideration the patient, but we have to take in consideration all the other patients that are vulnerable when we let someone into an area where patients are being treated. So it's looked at on a case-by-case basis. I know that there's been some exceptions made in some situations, but ultimately we're not only have to worry about the safety of the patient that is your loved one, but we have to worry about the safety of the patients of everyone else on that floor and what can be brought in from the outside. So all those factors are taken into consideration, and it's a tough thing. We've tried to even work through having some iPads available so people can talk to their loved ones and virtually, and try to make it as accommodable as we can. But it is a difficult situation to try to balance that, protecting both the patient and the family and those other patients that we're treating.
Yeah, understood, and just keep us updated, just so we're comforted that the conversations are being had, and I'm not doubting that they're not, but just keep us posted, when that transition, may or could, or if there's anything, especially the mothers. I mean, we honor our Cherokee mothers here as we should. I mean, just keep us updated on that. And I've got a couple more here. I took last month off, so I'm raring to go here. No, just help me with the conversations, doctor, just briefly. I've asked this before, but it's weighing on my mind. Like, in the medical world, accuracy of these tests, and I think I brought this up last time, but my friend I was talking about, man, he called me off the ventilator. Of course, I was so happy, tears coming down. I'm negative, Sean. The next day he's positive. Then the next time he took the test, the negative. Maybe another, and they had to get two. And then, when I went through, and your staff, I'm commending your staff and the follow-up. That was great job. But I went through one time, you're positive, 2 weeks of your life, stay on. So what's the conversation about the accuracy of these tests?
Well, that's a very difficult conversation, and it requires a lot more time than what we have here. But in a nutshell, the different tests test for different things, and some of these tests are molecular tests. Will even test for the remnants of the disease, even though and that's why some people may test positive for 20-something days past whenever they've recovered. Whereas other tests test for the active disease, but they're not as accurate as the molecular tests. So it's a balancing act on which tests to use and which one are more appropriate for the given situation. And I'm not a lab expert, and so I would leave that to them. But I can definitely try to get you maybe a white paper that describes that a little better. Because it is very complicated, and there's a lot of different tests out there right now that test for different in different ways. and the accuracy or the sensitivity can change depending on what that test is and whether or not you're symptomatic or not symptomatic. Some of those tests may not pick it up if you're not symptomatic. So we have to be very careful, and our team has worked very hard to use the most appropriate test and the most accurate test. There's been umpteen different, companies that have approached us, and everybody has their own spin on why theirs is best. So we evaluate them each time and have our lab and medical personnel that deal with that type or those specifics, and then they come back to us and say, yes, this is good, use it for these situations. Yes, this is good, use it for these situations. In some cases, we're using, tests that, for rapid tests, for example, they're very, very accurate, and we have backed up our tests in order to make sure that we're doing what we should do. In some cases, if we get a positive, we turn around and do a more in-depth test just to confirm that positive with some of these rapid tests to make sure that we're as accurate as we can possibly be. So I know that's a long way of saying it, but there's a lot more that goes into it. It's hard to just say this is it and this is that. There's so many different tests out there and different types of tests, and why you would have one test positive one day and negative another could be the difference in an antigen test versus a molecular test. So it's a very hard thing to explain.
Well, I know you guys are working hard, and it really wasn't aimed at Cherokee Nation Health. It's just something that's been on my mind, throughout the flood of news we get daily nationwide. One last thing, and I'll be quiet. The flu, of course, like you said, is coming. And this is my ignorance to medicine here. Now, will telemedicine be able to, quote, kind of diagnose the flu and help with that, or do they have to go get the old-fashioned flu test before they get any kind of, I don't even know what kind of medicine is it, but you can answer that. Will telemedicine be able to help us with the flu?
Yes, and so here's the way that works is once we, and I failed to mention, I think I skipped over one of the lines, but we have had our confirmed flu case already this last week, and so it's really early to have the flu case confirmed this early. So we're already in that mode. So what happens is we start down this line of testing, and when it gets to a point, now this year could be totally different because we've got COVID to deal with too, but in the past, once we got to a point where it was more community spread, we're having flu more, a lot more often, and it's showing up in different, a lot more prevalent, then the docs go to a symptom-based positive, which means they just diagnose off the symptoms. But again, this year is going to be different because of the COVID. COVID has some similar symptoms, so it may not, the CDC may not go to that type of diagnosing this year. They have talked about doing that with COVID, and then we started getting a lot of people getting off work and getting sent home for the minor symptoms because they were basing it without a test, and they kind of backed off that. So we'll have to wait and see what the guidelines come out, but it is possible. So if it's similar to last year, where you can diagnose strictly off the symptoms.
Thank you, Doctor.
Okay, Counselor Duncan.
Hey, Dr. Jones, I got a couple of questions. The first one is real simple. I just noticed that there's no top diagnosis by clinic in the report anymore, and that was always something I kind of like looking at. If I don't know if there's a way to put it back in there or not. But my main question is on the remdesivir study. I know the answer is probably a fluid answer, but do we know when we will know whether or not the results of that study will be met? When will we know if we can start sending folks home and treating them with remdesivir?
That will be, I don't know how soon those results will come out. As far as the top diagnosis, let me address that first. They rotate those there's 4 different things that go on in your report on that last page, and that hits every 4th time, I believe. I think there's 4 prescriptions, top diagnosis. I can't remember the other 2, but they rotate those reports every month.
Okay.
So, but as far as the remdesivir study, we don't know the results of that. It's a blind study, so they've got numerous partners across the nation that are taking applicants and doing the study, and then once they collect all that data, it'll be submitted. I'm sure it'll be scrutinized very a lot, just for, as all studies are, before it's decided to be safe to use at home or not. So I don't know those timelines. I know, all we know right now is the timeline of the study. There's an open window right now to do the study, and then once that window closes and those patients complete the study, all that information will be packaged and given to Gilead, and then Gilead will take it from there. So we're just a part of it, and glad to be a part of it. It was an extensive process, and we were glad to be accepted into the study.
Yeah. Well, thank you. I was talking with the doc at one of our facilities, and that's what they were saying was, how big of an honor it is that we're getting to take part in this study. So great job on making that happen, and hopefully it's going to help a lot of people out.
Speaker Byrd.
Yes, Dr. Jones. I just want to commend your doctors and nurses and staff for the efficiency and promptness in providing and administering the flu vaccine. I participated in that, and as several vehicles that were lined up, and Dr. Montgomery was out there, and you guys were providing services in full force, and I just want to commend your staff because they're on the front lines every day, and of course outlying clinics are doing as well, but I just want to commend the staff. You guys are doing an outstanding job under the circumstances. We just say, well, don't, to all of you. Thank you, Madam Chair.
Thank you.
Does anyone else have any questions? Yes, Councilor Austin.
Dr. Jones, you spoke of trying to recognize your staff who is rising above in various ways and the challenges of that right now. Currently, on social media, you guys will introduce new providers. I don't think that's real consistent, however, because I saw like 2 recently, and then it's been months and months and months ago was the last time I saw that. So I suspect that's not real consistent. But I really appreciate seeing that in social media, seeing the new providers in social media. And I suspect the public does as well. It shows that we are working hard to make sure that we've got the people necessary to take care of our people. And I think the same can be done with those employees who are needing to be recognized as well through social media. But in addition to that, I would ask, when you send out a social media post about an employee or a new provider, if you would just send that same exact message in email to Gail to disseminate to us through email rather than social media, that'll give us an opportunity to also reach out to these folks and say, thank you for the work you do. Thank you and congratulations. And I can't help but think that could be meaningful to them at times.
You can definitely request that communications do that. We turn our stuff into communications as when they are the ones that release that information and disseminate it out, that we can definitely request that they do that.
Thank you.
Okay, anybody else with questions? Okay, Dr. Jones, how many of our patients are being seen through telemedicine?
How many of our patients are
Being seen through telemedicine? Yes.
being seen through telemedicine?
Yes, sir.
Approximately, right now, we're trying to build our schedules to a 50-50 ratio. It depends, it varies quite a bit from clinic to clinic and provider to provider. But ideally, we're trying to build our schedules to a 50-50 ratio so it's offsetting. We can utilize our staff that's on premise completely. So if, for example, if one provider is doing telemedicine visits in the morning, then that staff can float over and help the provider that's seeing patients face to face. So we're trying to work on some different efficiencies because we have a lot of staff out that will allow us to be a little more efficient and treat more, have better access and treat more folks.
Wonderful, wonderful. I understand we have a new deputy medical director. Can you share anything about him with us?
Dr. Brett Gray has accepted the role to be the assistant medical director to Dr. Montgomery. I think he's been, I don't have his bio right in front of me, but I think he's been with Cherokee Nation for 18 years. He's worked as medical director at several of our clinics and will bring a perspective from the outlying, from our clinical that are outlying clinics back to us that maybe we don't have historically. So he's going to be a great addition to our team in helping us build those efficiencies and build this healthcare system. And that's kind of what the goal that we have, or our vision is that we are a healthcare system that's comprised of all of the clinics, hospital, and then all the clinics. So he's going to help advocate and help us to keep moving in that direction.
Very good. Dr. Jones, I recently saw an ad. One of the neighboring towns around Tahlequah was recruiting registered nurses, and they were offering a sign-on bonus. Does that hurt us in our recruiting?
It's hard to say. We are recruiting also, and we are looking at different strategies for recruitment. Those sign-on bonuses that you're seeing, there's some fine print that goes along with that. With you sign on, and the bonuses are reflective to the time that you sign on, and there's which we would like to. We've looked at that strategy. It's not ruled out yet. We're trying to figure out what the best strategy is for us and to recruit our nurses and keep our nurses in this area. We'd like to keep nurses that live in the communities where they work. There's a little more accountability to the patients, and we feel like it gives more of a family or a closeness to the clinic, to that community. So we're definitely looking at different strategies to help us fill that need.
Thank you. I have another question, Dr. Jones. This may seem unusual to ask, but when you drive through the COVID-19 testing line, who's paying for that test? Is it Cherokee Nation or is it our federal government?
Well, we're getting those tests. Some of those tests we are purchasing, and some of them are coming from Indian Health Service. And some of the tests we've used our CARES Act money for. So it varies. For the longest time, we were not getting anything. We were not being able to purchase. Everything we were getting was allocated to us. Now, in the last month, those allocations have started to loosen up, and we've actually started to be able to purchase some testing. The amount that's allocated for purchase is still very, very small. So we're still working with those contractors and those vendors to try to increase that amount. But the federal government has taken most of the supplies in the beginning, and some of those companies are just now starting to catch up where they have some for sale. So in the last 2 weeks, we've started to see a little bit of allocation starting to float in that we've been on back order for 6 months. So we're hoping that that's going to loosen up, and we're going to have a lot more. But typically in the beginning, for the first 4 months or so, a lot of those tests were given to us by the federal government, and we did not have to purchase them. We still have to run them. We still have to pay for the staff to run them and all the stuff that goes along with that. But the tests themselves, the swabs themselves, were given to us by the Indian Health Service.
Thank you. Chief of Staff Inlow, is there something you'd like to share?
If you're done with your question, Dr. Jones. So in addition to health, I applaud our health team for the work that they've done for the last several months. And our numbers continue to increase across the state. If you paid attention to the state of Oklahoma, last Thursday and Friday, we set records as a state of having more than 1,500 cases, new cases in those 2 days.
you
speak up?
speak a little louder? Yeah,
Okay.
thanks.
And so, we talked about remdesivir a little bit today. We kind of introduced it a couple of months ago, or about a month ago, talking about this partnership with Gilead to start this. And the reason that's important is because the bed space in Oklahoma has waned over the last several weeks. Well, it's spiked in the last several days, and it is getting more and more difficult to find bed space available for somebody that needs it in Tulsa, Oklahoma City markets, and even the surrounding counties or states. And so the remdesivir trial, as short as it is, actually allows us to see patients and treat them where typically they would have to be in the bed in a hospital, and they may not be emergent and needing advanced care inside the hospital. And so by doing the trial, it allows that individual to seek treatment in an outpatient clinic facility, so we're not taking up a bed. So warning you that number is coming towards us as a state. And we'll need to continue to watch that and see what bed space looks like across the state. But Dr. Jones, if we're in about 800 beds occupied in the state, where we've been running about 500 or 600 as recent as a couple of weeks ago, if I'm correct. If you can double check that number to make sure I'm accurate. So I did want to reemphasize that, and that's why remdesivir trial is so important to us. And then the other thing I'd like to make note of is we are working with CMB and developing an employee clinic in the Catoosa market for those employees that are CMB employees in the Catoosa area. And so we are working very quickly to make that happen. So we're partnering with CMB to help get an employee clinic there for those employees, nearly 7,000 employees that CMB has in that market. So I did want to update you on that as well. So Dr. Johns, were my numbers pretty close?
Yes, sir.
Okay. So thank you very much.
Thank you. Counselor Crittenden?
Yeah, Todd, I texted you the other day, just wasn't urgent. Like the state map, okay? You know, we're hearing about these numbers. Compare our map, if it's correct and okay to do that here, but it's just confusing to see there's some, you know, it looks positive when they say, hey, Adair County's 15 point something. And then, you know, but if your eyes are open at all, you know, each of us probably knows 15 people ourselves. And, you know, and I know that number's not just one person, you know, but I know you've been studying this, so help me see our info versus state, because it seems to contradict each other sometimes.
Well, actually, there's actually a bunch of maps that are out there. So you get some from the Oklahoma State Department of Health, you get some from Oklahoma State Department of Education, you've got Harvard Global Health. There are 10,000 ways to slice and look at data. Oklahoma State Department of Health factors in not only cases per 100,000, but they're also factoring in bed space availability across the state that triggers their alert systems based on their color coding. The data that we are looking at is strictly based on cases per 100,000. So we're not, as Cherokee Nation, we're not monitoring the bed space availability. I mean, we're monitoring it, but we're not publishing that as data, and that's not driving any color-coded system related to that. State Board of Education is pretty similar. They have different strata for so they've got orange level 1 versus orange level 2. Orange level 2 really is just a difference in the number of cases per 100,000. So that there's a bunch of different ways to slice and look at the data. When we publish our data, we're just looking at it straight numbers per 100,000 cases or per 100,000 people. And so as Dr. Johns was talking, you know, some of those counties with very low population, I'll take Nowata County, for example. If they had 50 people that test positive, it's going to make their numbers explode because they have a very low population in that county total. Whereas opposed to 50 positive cases in Tulsa County is not going to be as elevated as Nowata County would be because it's much more rural community. So that's the difference between the data and how you look at it. We're just simply reporting on number of cases per 100,000 people.
Cases. Now, the state, looking at Adair County, of course, there's not a whole lot of beds in Adair County.
Right.
So are they figuring in some of that too with their numbers and?
So the state, when they look at that, they look at the state as a total. So they're not looking at the county or where that person tested positive and the number of bed spaces available. They're looking at bed availability across the entire state.
Okay.
So when Oklahoma City saw a huge surge and the bed population surged, it made the entire state look bad because the Oklahoma City market was inundated as well as Tulsa County. And so when they report the total number of bed space available or utilization, they're looking at the state as a total. Now they have started to discuss looking at that data on a regional basis. And so you'd have, I think, Dr. Jones, am I right, is it 4 or 5 regions?
5.
Okay, so they're looking at the possibility of slicing that data into smaller regions and understanding positive cases in that region versus bed space availability. And Dr. Jones, I'm forgetting, there's like 5 or 6 criteria that the state looks at in their reporting. And it was the 7-day trend, number of cases per 100,000, bed space availability, and there was one other.
Well, they also are taking into consideration different types of testing modalities because they're taking the antigen test in also, which currently we're not using. We're just using positives, and so there are some other factors going into the state numbers that are causing those numbers to be different from ours.
So the reporting that we have on our website, we report some of the state health department's data as well as ours, because ultimately all of our information is uploaded and sent to the state through the FIDO system, which is a state epidemiological system that all the hospitals and county health departments upload their information into. So, and
Thanks for that.
you bet.
Okay, Counselor Shambaugh.
Dr. Jones, Chief Staff, this probably will be addressed to both of you. And I talked to Chief here recently. I've had the, I guess, misfortune of having to speak with several families here recently who have lost some elders, speakers to COVID. And in asking, you know, having discussions with these families, I think the thing that I have heard the most is, you know, these are ordinary people who have never experienced anything like this before. When this happens, they don't really know what to do. They don't have the means to even protect themselves and their families. They don't have masks. They don't have gloves. They don't have anything like that. And they really just don't have a whole lot of knowledge of this disease other than what you hear, you know, on the news or whatever. But nobody has ever got really with them and said, hey, this is what you need to keep yourself safe, and even disinfectant, you know, for the rooms and things like that. But I did talk to Chief and express my concerns about, is there any way that we could, I think we had something for when people were on assistance or LIHEAP or something, and they were identified that they were given a care package, but there's a lot of people who are not on that assistance who are getting this disease who are not equipped to have the masks and the gloves and to stay safe. Is there any way we could come up with maybe like a care package when we get a report of those kind of families? I know the logistics of getting it from being reported to making it happen may be an issue, but is there anything that we can do to help these families out that really they just don't have a clue what to do when a loved one gets it?
So we have taken care of a few of these one-offs where a family member contracts the disease and in some cases has passed from it. And either the elder that's in the house or it was an elder that passed, we have given care packages to those families to help them go in and help sanitize the space. Early on, we were asked if we could go in and sanitize that space, and I just don't know how we could physically make that happen. So, we've got the hypochlorous acid that you've heard us discussing here before. It's a neutral analyte. We make that. It's basically electrolyzing salt water, and it lowers the pH of that. Several entities are using that as well. It is a disinfectant, is a contact kill, meaning that you spray it on that surface. It doesn't remain as an active agent on that surface for hours or weeks. It's really just at the point of time that you spray it and wipe it down. So, if you have elders that are like that, that have had a family member that's gotten severely ill from COVID or passed, and they need assistance, then, refer them over to us and we'll see if we can take care of them. Recently and I can't remember which of the council members were there, but we did a drive-through meeting, and we handed out what we called care packages, and it was a canvas bag, and it included masks, gloves, hand sanitizer, sanitizing wipes, and then we put in some additional literature and information in there. We're getting more of those bags to be able to supplement that and get that out. So that would be what I would say we could probably try to figure out a way to do that. And so we're trying to increase our inventory to help deal with that.
Well, I would just relaying what families had said, and talking with the chief, sometimes it's little things that are big things when you're dealing with people. And even a phone call, even a prayer from deputy or something like that. I mean, I haven't talked to deputy yet, but I'm sure he would be willing to do that. But that, anything to raise your spirits and then to show that, yes, we do care, and this is, we're trying to get these things to you. We're not going to come in your house and clean it, but here it is if you can use it and something of that nature. I think that would be important to people to hear from our administration if they did get it and they know that we care and we're doing what we can to try to help them.
Yeah.
Counselor, I do want to mention too, as I said before, we have a case monitoring team made up of nurses and trained individuals that once someone becomes positive, that they go on that team's list, and that team is responsible for that's something our health system's doing that I don't know of any other health system that is doing that. So we call them, we talk to them, we give them advice, we answer questions, we give them the ability to contact our team members directly. And so that is something that we have done from the beginning, is reach out to anybody that's a positive case and help monitor them and help give them advice to get them treatment if they start progressing, or just encourage them as they're moving through it, and help them monitor themselves and their family members daily. So that's something that we have done from the beginning and is unique to our health system.
Well, that's a good thing that you're doing. I just know that there's been several who have had no contact with anybody, so. Thank you, sir.
Counselor Dobbins.
Sorry, Dr. Jones, I should have asked this earlier, but in practice, have we released the names of our new hires, new physician hires in our system? Have we done that in the past, or have we publicized that, or?
Typically, we do what we call internal marketing. We've got a team that we've put together to focus on that so that other providers know these providers are coming on. And then we do turn that information over to communications to put out, to work into their communications program where they can, depending on what information is coming out at the time. So we do announcements and we do get that information out We haven't done the best job of that in the past, so we have a team that's devoted to that and trying to get that information out. And in the long run, we're hoping that will help also on our purchase referred care or contract health, that we are able to find those individuals that have certain specialties or that have certain skill sets, that we're able to keep those patients in our own system instead of referring them out.
I just know a lot of constituents of mine and others in the rural areas, they don't do social media, and many don't have internet access, so hopefully social media is not the only way we get the word out.
I don't know if they put that in the paper or not. I'm not sure if they do that typically or not. That would be a question I'd have to ask communications on how they did that.
I was going to say, Dr. Dobbins,
We package it up and we turn it over to them. So.
I don't know that we've done that in the newspaper, but that's definitely something we could take a look at, and if nothing else, in the Phoenix.
Get your
For sure.
opinion.
Yeah.
Thank you, Dr. Jones.
Counselor Deere?
Yeah, I just had a real quick question. What is the location of a drive-through closest to Tulsa for flu immunization?
I would say, well, we have Muskogee, it would be close to you. Nowada's a little further away. So any of our clinics are having drive-through flu clinics every day. So we usually do the COVID test in the morning, and then we switch over and start doing flu clinics in the afternoon.
So Muskogee or Nowata is probably the closest ones?
Probably, I would say. I'm not familiar with
I was going to say, Dr. Jones, Counselor, there may be some one-offs. So normally during this time of year, without COVID, we would be hosting community meetings, and a lot of our public health team would actually come to your community meetings and deliver the flu vaccines. But since we're not gathering in that way like we normally do, they have been trying to find unique ways to try and create opportunities. So let me double check that list. There may be some opportunities that are closer to the Tulsa market than those clinics. They are trying to find, I know that they're working with several schools, public schools, which is really focused on the students and faculty that are in those school systems, and not necessarily open to the public, but there may be some other areas that they're looking at, and I just can't remember. That list is probably 200 places long as far as the number of places, so let me double check that and make sure. There might be an opportunity
That's
coming
what I was
up.
asking, because a lot of constituents are like, we're having to drive, all the way to Nowata, Muskogee, and I know they know the clinic's coming and we can do it then.
Yeah.
But in that interim is where I was wanting to try to find somewhere to really post it,
Yeah.
to let them know.
Let me double check that to make sure, because I know that there's about 200 on that list that they've been working on.
so the clinics are consistent every day during the week, but the list, published the list, I thought it had already been published. I'm pretty sure it has. It's got over 250 dates and locations that we're going to be at different, with those 5 teams that we talked about that are going out and setting these up. So, but if you're looking for consistency, then the clinics are consistently doing that Monday through Friday.
I'll see if we can, if there's something missing, I'll see if we can figure out a way to add something that's a little closer.
Okay, any other questions?
One comment, if I might, and it's in relation to Councilor Crittenden's question, and I couldn't remember what some of the other factors are. So with the state of Oklahoma, their color code system is really based on the state's response and readiness to COVID-19. Whereas a lot of the other data that you see is really about how fast the virus is spreading in a community. And so the state looks at that, but they also look at their readiness. And so one of the other things that they use as part of their criteria for their color coding system is the number of days of PPE available in the hospital. So if Tulsa market sees a surge and they're burning through more PPE and they have 2 days worth of inventory available, and I believe it's less than 5 days. So across the state, if they have less than 5 days of PPE available, then we would go into the red on that. So what state looks at is not just the number of cases and looking at how the virus is moving through the system, it's also about the readiness of the state to handle any increase of cases in the state as a whole. So they look at several different factors, and part of that is being PPE available and hospital bed space available across the state.
I think every little county is accurate. What I'm saying is a lot of things are based on what color this little bitty county is. And, you know, PPE readiness, I think we're pretty good, you know, but
Well, I do. I think, you know, it just depends on how you look at the data. And, you know, like right now, I think Cherokee County has dropped back down into orange category. I think we'll quickly jump back up into that because I think we're at like 23.5 or so today. Adair County had been in the orange for a few weeks, but now that they've popped back up into the red environment. And if you look across the state, most of the counties now have turned into a red county, meaning that their number of cases is greater than 25 per 100,000. And so I think you're seeing a lot of rural areas that were somewhat insulated from urban exposure. That's why you see an explosion in New York, in Los Angeles, where population centers and people are densely clustered. And then the rural areas have been somewhat insulated from that. And it takes longer to move through that just because people don't pack together in the subway. They don't pack together on a bus. They don't pack together on a sidewalk. We're a little bit more socially distanced. And that's why the spread of the virus hasn't surged like we saw what happened in New York and Los Angeles and other metropolitan areas. So all in all, I think, yes, the data's correct. It's just different ways of taking a look at the data.
Anything else? Anybody else have any questions? Dr. Jones, I want to thank you for an excellent report today. Thank you so much. And Chief of Staff Enlow, thank you for joining with us and answering our questions. I would like to tell everyone that if you're going to wear a mask, may I encourage you to wear it correctly and cover your nose. Your nose is a portal of entry, and just for your protection and those around you, wear the mask correctly. Is there any old business? New business? Announcements. Our next meeting is November the 16th. I'd like to encourage everybody to vote the next election. That being said, I'll call for an adjournment. Second. All those in favor?
Aye.